Welcome to today's webinar entitled TB and Tobacco, Treating Tobacco Dependence in Special Populations, sponsored by the Southeastern National TB Center. My name is Karen Simpson, Co-Executive Director at the SNTC, and I'm moderating today's webinar. Our speaker today is Stephanie Nixon. She's a training coordinator and specialist at the Southeastern National TB Center at the University of Florida. She is a certified health education specialist, and she's certified in public health. Before coming to SNTC, she was a training coordinator for the Swanee River Area Health Education Center, where she provided trainings on the effects of tobacco and cessation counseling techniques for healthcare professional students. She is a certified tobacco treatment specialist, and she continues to help tobacco users quit their nicotine addiction through in-person counseling groups. Now I'll turn it over to Stephanie.
Hello, everyone. This is, as Karen said, the last webinar in our series, and we're going to be talking about treating tobacco dependence in special populations. I'm going to make a note about our objectives. We aren't going to cover that third objective, dealing with treating tobacco use among pregnant women, though that is an important topic. We're just not going to cover it during this webinar, but we didn't have a chance to take that out, so I just wanted to let you know ahead of time. So these are some of the special populations that we tend to focus on when dealing with tobacco use. The ones with asterisks we're not going to cover during this webinar, but I just wanted to let you know that there is research and literature out there about specific interventions when working with those populations. But some of the ones that we're going to talk about during this webinar are hospitalized smokers, HIV-positive smokers, diabetic smokers, smokers who are homeless, those who have low SES or limited formal education, racial and ethnic minority populations, and those with mental illness. And we're focusing on those because those are also populations that we tend to see that are also affected by TB. So hospitalized smokers. It's very important that hospitalized patients attempt to quit using tobacco. Tobacco use will probably interfere with their recovery and their overall health, and chances are, whatever reason that brought them into the hospital, we can have a chance to help them recover by quitting that tobacco use. And everything that I'm going to talk about, I want you to always keep in mind that our focus is on TB, so think about those TB patients and those who may be in the hospital or other areas of isolation. When you're hospitalized, you're motivated to make a quit attempt. One, you can't smoke in a hospital in the first place, and I know in Gainesville we see some of our patients leaving the hospital to go stand on the edge of the corner to try to smoke. Your patient might not be able to go do that either, so it's really a great time for them to go ahead and quit. And this is obviously a great environment to prescribe some of the medication that we talked about in the last webinar to help alleviate withdrawal symptoms. If you're already dealing with a patient who has TB and they feel bad enough, we want to encourage them to quit, but we don't want them to also feel terrible while they're going through withdrawal as well. And then consider the fact that patients in long-term care facilities should also receive tobacco dependence interventions. It's a great moment to use this to promote smoking cessation. It's a great teaching moment. And treatment is shown to be effective when you offer it to hospitalized smokers. So just think about those scenarios, think about your TB patients and how you would handle this. So treatment, and this really goes for, it's a general model that we can really apply to all populations. You need to first determine if the hospitalized patient is ready to quit smoking. If they are ready, you can start counseling them using the 5 A's, which we talked about in one of our previous webinars, the ask, advise, assess, assist, and arrange. If they're not ready to quit, you can counsel them using the 5 R's, which were the relevance, risks, rewards, roadblocks, and repetition. And even if they aren't ready to quit, they still can't smoke in that environment, so you can still give them some type of NRT to at least make their stay more comfortable. And you never know, they might decide they're going to quit after they realize, hey, this is kind of working, I don't feel as bad. So use pharmacotherapy selectively depending on the situation, and then arrange follow-up for tobacco cessation therapy so you ensure that they stay abstinent from that tobacco use. And again, because you're treating TB patients, you're in a unique situation because you know you will be able to follow up because you know you're going to be seeing those patients. We also know that providing counseling during hospitalization is important, but it's also important to continue to provide some type of counseling or education after discharge. So let's talk a little bit about a patient scenario. So Candace is a 32-year-old female being treated for TB, and she's in the hospital. She smokes 1 pack of cigarettes per day. She's unsure about how successful she can be in quitting, but she knows that she needs to quit. She has been unable to maintain abstinence for more than 2 months, and she's never used NRT during a quit attempt. So if you're given this scenario, and we're going to put a poll question so that you can get a chance to engage and participate, what would you address first? Are you going to address their willingness to make a quit attempt? Will you discuss types of NRT used? Will you discuss stressors in life? Or you won't address anything, you were there to treat the TB only? So go ahead and take a moment to see which one you would address first. Okay, so it's looking like the overwhelming majority is choosing that they would assess their willingness to make a quit attempt. And I would agree with that. We can't pull the cart ahead of the horse and start talking about types of NRT if we don't even know if they're interested in quitting. And discussing stressors in life is good too, but first, again, we have to see where are they with even wanting to quit in the first place. So Candace is in that contemplation stage, so it's important that you are highlighting the ambivalence. Get her to start eliciting self-motivational statements. Get her to start saying, I think I can do this, or I was able to quit for 2 months. This is what I did during that time, and it worked. Emphasize the discrepancy between where she is. At this point, she's hospitalized, she has TB, she doesn't feel well, and her end goal is that she wants to feel great and she wants to complete her treatment. So you have to highlight that discrepancy, and then explore what her goals are. And then again, because she's in a hospital, see if she can get a patch. It will ease her comfort if that's something she's able to do. So let's switch gears to diabetes. So I'm not going in depth about TB and diabetes, but just as a refresher, the risk of developing diabetes is 30 to 40% higher for active smokers than non-smokers. There is a positive dose-response relationship between the number of cigarettes smoked and the risk of developing diabetes. So essentially, the more you smoke, the higher your risk for developing diabetes. And then people with diabetes are at a higher risk of progressing from latent to active TB. So again, it's important to always remember the link between TB and all of the populations and issues that we're talking about. And then we start talking about how tobacco also affects that and why we really should be treating all of these together. So tobacco and diabetes. Tobacco use can increase your blood sugar levels, and that can lead to insulin resistance. So again, just like I said, the more you smoke, the greater your risk of diabetes. People who smoke heavily have almost double the risk of developing diabetes compared to those who don't smoke. And we define a heavy smoker as more than 20 cigarettes a day. So that's essentially if you're smoking more than a pack a day, which most of our smokers that we interact with do, that's when you're going to start seeing that double risk for developing diabetes. And then people who have, or people with diabetes who smoke are more likely than non-smokers to have trouble with that insulin dosing and controlling their disease. And smoking is responsible for about 9,000 diabetes deaths in the U.S. per year. So when you're thinking about talking to your patients, you want to let them know that if they have diabetes and they smoke, they're more likely to have heart disease, kidney disease, poor blood flow in the legs and feet, retinopathy, and peripheral neuropathy. And then smokeless tobacco users also have a higher incidence of diabetes. And I point that out because people still have this perception that smokeless tobacco is fine, it's not harmful, it can't do anything to me, and that's just a result of tobacco marketing. So managing your diabetes and smoking. Diabetes treatment and management can include just having a healthy diet and some type of physical activity program, losing weight, taking medicine to help control that blood sugar so that your body can utilize that insulin better, and patient education to address problem solving or coping skills that are needed to manage diabetes and its complications, medicine to control cholesterol and blood pressure, and smoking cessation. Now I put asterisks next to some of these because that's also what we teach people to do when they are trying to quit tobacco. So managing diabetes and tobacco really can go hand in hand. If I'm already talking to you about some of the things for diabetes, why not also talk to you about how you manage smoking and do them together, because that's giving you a better chance of treating that TB or preventing that LTBI from progressing to TB disease. So again, benefits of quitting. Your patients will have better circulation, less resistance to insulin. They will see a decrease in the risk of those diabetic complications, lower blood pressure, lower cholesterol levels, and better glucose just means they have a lower A1C over time. And this all means that they're able to better manage their TB. And then those benefits continue to increase with the length of time that they remain tobacco-free. So again, as you're talking to your patients, highlight that importance of quitting tobacco in relation to the TB and the diabetes. Those are two major things they're already dealing with, and they might not want to focus on the tobacco, but if you let them know, here's how all of these things relate to each other, they might be more likely to at least consider a quit attempt. So HIV-positive smokers. So someone with untreated LTBI and HIV is much more likely to develop TB disease during their lifetime than somebody without HIV infection. Among people with latent TB infection, we know that HIV infection is the strongest known risk factor for progressing to TB disease. And then if you have HIV infection and TB disease, that is an AIDS-defining condition. And so we know that HIV weakens the immune system, and smoking also is weakening the immune system. So you're much more likely to get sick when you have HIV and you smoke. So how much more so when you also have TB on top of that? So again, our whole goal is that we're trying to give you a better quality of life. We're trying to make sure you complete your TB treatment and you're responding to the meds. So it's important that we address that tobacco use. So HIV-positive smokers are more likely to smoke than the general population. We talked about this in the very first webinar, but about 1 in 5 U.S. adults smoke. But among those living with HIV, the number of people who smoke is about 2 to 3 times greater. And we do have a clinical concern because HIV-positive individuals are living longer. So if you're living longer and you keep smoking for that same amount of time, you are now going to start seeing some of the same issues we've been seeing in the general population. So smokers living with HIV have a poorer response to antiretroviral therapy. They have a shorter lifespan than those who don't smoke. Higher mortality rates, they have a lower quality of life, and then they have an increased risk of different opportunistic infections. And this is all compared to people who still have HIV, but they are non-smokers. So what's going on here? If you have HIV and let's say you also have TB, well, why are you still smoking? HIV-positive smokers tend to underestimate the effects of smoking on their health. And they also report that smoking is an effective way to cope with the stress of their illness. And a lot of them do believe they're not going to live long enough for the health effects of smoking to matter. But we as health professionals know that's not the case. The life expectancy for someone who has HIV is almost that of somebody who doesn't have it. So we are going to start having issues with people who have HIV and they're still smoking. And that's something that you've got to keep in mind. That's something you've got to also talk to your patients about to start dispelling some of those myths they have regarding their illness and smoking. So what's going on? What is affecting their smoking behavior? We know about 50 to 70% of people infected with HIV are current smokers. And then we're seeing that we really need to be including smoking treatment protocols in our models of HIV care. But regardless of that, we're not treating these people who have HIV and also treating them for their tobacco cessation. So we already know on a grand scale, socioeconomic disadvantage is a pretty well recognized predictor of smoking in our general population. And then economically and socially marginalized people still represent a good amount of the proportion of people who are affected with HIV. So we know that they're already at risk to be using tobacco. We know that they are experiencing a disproportionate amount of daily stress and discrimination. They're having less education, and they have social environments that lends itself to smoking. These are the things that we tend to see with people who are smoking. And they have less social support and network members that are supportive of quitting tobacco. It's almost not the cool thing to do to quit tobacco, which makes it that much harder. We also know that tobacco use can occur with other substance use, and then the rate of smoking also increases when you're using other substances. And recreational substance use and substance use disorders are well-known risk factors of HIV. So again, I'm mentioning these things because you can see they all go hand in hand, and you can't treat one piece of this without the other. Studies documented that abusers smoke higher nicotine cigarettes, more cigarettes per day, and they have higher addiction scores and have increased carbon monoxide, nicotine, and cotinine levels than non-abusers. And then relapse is common following treatment for both smoking and other addictive substances. So you've got to keep this in mind when you're talking. That is a hard population to treat, but you can still do it. You just have to know what barriers are you facing and how can you address that. For physical and mental distress, and actually I'm skipping that, psychiatric comorbidity. We know that higher rates of cigarette smoking, greater nicotine addiction, and abuse of other substances are also associated with mental disorders. And I'm not going to spend a whole lot of time on this because we will talk about it later. And then we know that HIV, it takes a hit on a person's body. You do go through some type of physical distress. You do go through some type of mental distress. And people use tobacco as a way to cope with that. A lot of times they're using it because they feel like it's helping them not only deal with the mental issues, but it's making their pain go away. So they are less likely to report, or they're more likely to report less pain. And then supporting beliefs. I kind of touched on this earlier. People living with HIV believe they're not going to live long enough to suffer the risk of tobacco. But we do know, and this is the good news, several researchers have found that HIV-positive smokers are interested in quitting. They just believe that they can't quit successfully, and that's a barrier. We've got to increase that self-efficacy so that they feel like they can do it. And then dealing with treatment adherence, a large majority of smokers who try to quit without treatment, so without your help, fail within 2 weeks. So the odds of an HIV-positive smoker quitting without some type of cessation treatment is very slim. And we don't look at tobacco cessation as a treatment regimen. We know with TB, you need to take this pill and this pill at this time every single day for this amount of time, and we know that. But we don't treat tobacco cessation the same way, so many people don't adhere to that treatment of we need to be following up with you periodically. And if you are not adhering to that smoking cessation treatment, you are more likely to have an unsuccessful quit attempt. So when you're talking to HIV-positive smokers about quitting, you can let them know that quitting lowers their risk of cancer, of heart disease, again, tuberculosis, which is why I have that bolded, because that's obviously why we're all here, COPD, pneumonia, stroke. They can reduce HIV-related symptoms and have an improved quality of life. So you've got to tailor your message to how quitting helps them with their TB and HIV. Again, it's all about what's important to your patient and what they can get out of this quit attempt. Help increase their self-efficacy because they have a higher chance of relapsing or having an unsuccessful quit attempt within those 2 weeks. Monitor them and have a plan for the first 2 weeks. Have them set up a plan and let them know what's about to happen. And then get a plan in place for coping with withdrawal. Again, you already have TB. You're probably not feeling so great. And you have HIV. They're not going to want to also feel bad because they're quitting smoking. So let's make sure we know how they can cope with that, and let's see what medicine we can get them so that they at least aren't dealing with the negative effects of that withdrawal. So we're going to do another patient scenario. Lewis is a 42-year-old male. He is an HIV-positive smoker and has TB. He smokes 2 packs per day, but when he's with his partner, Neil, the number of cigarettes he's smoking increases, and he smokes within the first 5 minutes of waking up. He's been sober from alcohol for 1 year, but he does still get tempted to smoke and drink when he's around his friends who are drinking and smoking, but he says he's ready to quit. So for this next poll question, I want you to decide what you would address first. Would you start talking about the types of NRT used? Would you set a quit date? Would you discuss triggers to smoking and alcohol, or would you just do nothing? You are here to treat TB only. Okay, so it looks like a majority of people are saying they would discuss triggers to smoking and alcohol. So and this is not a perfect science, I went between that one and set a quit date. You really need to do both, so I'm glad to see the next one is that people were saying they would set a quit date. I wouldn't go yet into talking about types of NRT use because we've really got to find out what are those triggers. It's great that he stopped using alcohol for sure, but if he's still noticing those triggers or he's still getting tempted, you need to reinforce what does he do when he sees that his friends are drinking to make sure he stays on that path. And then how can we also address the smoking? And then I would absolutely pretty much after that go ahead and start talking about setting a quit date. And again, that's not an exact science. Most of the people, we try to get them to set a quit date because in your mind it's letting you know I've got to go ahead and quit. And we encourage people to write that down. It's too easy to forget a goal or change our mind when we have something floating in our head. But when you write it down, it's almost making this connection that, okay, I've got to quit. This is the day I'm putting it down. So if you were on the webinar last time, I'm just throwing this next question out there to see if people retained anything about the NRT. So let's say we've gone through the triggers. We talked about a quit date. What kind of NRT would you start them on? Would you start them on the 14 milligram patch, the 21 milligram patch, a 2 milligram lozenge or gum, or would you do 21 milligram patch and a 4 milligram lozenge or gum? Okay, so it looks like the majority of people said the 21 milligram patch and 4 milligram lozenge or gum followed by the 21 milligram patch. I would absolutely do the 21 milligram patch and 4 milligram lozenge or gum. And we dose that by, if you're smoking about 10 cigarettes or more a day, we would absolutely start you off on 21 milligram patch. But because they're also smoking within the first 5 minutes, that tells us you're really addicted. You need to also try to use that 4 milligram lozenge or gum. Now, there are some people who say, I don't want to use both. They just don't want to do it. So we would also say, as a backup, you could use a 21 milligram patch. 14 milligram patch is probably too low for them. He's doing 2 packs per day. So 14 milligram patch isn't going to quite give him enough nicotine. And then that 2 milligram lozenge or gum, since he's smoking within that first 5 minutes, also probably won't be enough for him. So it looks like the majority of people were dead on with that. So that's great to hear. So let's talk a little bit about homeless smokers. So at least 70% of all homeless individuals smoke, which is about 4 times that of the general U.S. population. And it always amazes me to see that because obviously this is a group that is struggling financially with housing, yet they're smoking at a higher rate than those people who are probably a little bit more financially secure. Tobacco-related chronic diseases are among the leading causes of morbidity and mortality among homeless adults. We see that cardiovascular disease is the primary killer of homeless and formerly homeless individuals. And then COPD is about 2 times as high as in homeless individuals as the general population. And again, we're seeing that homeless individuals suffer higher rates of death due to circulatory and respiratory diseases than domiciled individuals. Homeless individuals are susceptible to various health concerns such as HIV, diabetes, hepatitis C, and obviously tuberculosis. And then the conditions that they are in are often exacerbated by tobacco use. So we see a lot of homeless individuals suffer from medical conditions that are a result of exposure to the cold, poor nutrition, hygiene, limited access to health services, and then you're also looking at their risky behaviors, including tobacco use. They are at least 3 times more likely to die prematurely than the general population, and then we see that more than 5% of people with TB reported being homeless within the year prior to diagnosis. And people who are experiencing homelessness do have a high occurrence of conditions that increase TB, which includes substance use, HIV infection, and congregation in crowded shelters. And as we all know, that combination of conditions is favorable for spreading TB. And then people who are homeless often lack that easy access to medical care, which is required to make an early diagnosis of TB. So looking at homelessness and smoking behavior, A majority of smokers started smoking even before they lost their housing. Most were exposed at an early age by family members or peer pressure, and that's usually what we hear all the time. I want to say the average age I tend to hear people say they started smoking was maybe 13. I would say some less, some more, but in general it's around 13 to 14 years old. Some also began in jail, in the military, or other substance use abuse treatment programs. And if you've ever worked with those treatment programs before, their focus, and we'll talk about it later, is to get the person off of whatever drug they're in. But so many of that population also smoke, so they might go in there and they pick up the smoking while they're trying to get a handle on whatever other substance they were using. And then these individuals might use alternative smoking behaviors, so borrowing, sharing, or selling cigarettes, purchasing single cigarettes because that's cheaper. Sniping, which is searching for partially smoked cigarettes on the ground or ashtray, which I know I've seen before just walking around, so I'm sure you've seen it as well. And then switching to cheaper tobacco products. Many homeless people are continuing to smoke as a way to reduce their stress and their boredom and to cope with depression and other mental illness, even though research does show that tobacco and nicotine addictions actually increase anxiety, and some make the mental health conditions worse. Some homeless smokers think that being able to obtain cigarettes give them a sense of hope and self-worth, and this is important to know when you're starting to talk to them about tobacco cessation. So then what are the challenges? Shelter policies are not often aimed at reducing tobacco use. To them, that's not their primary priority. Shelter employees believe that quitting tobacco would increase their clients' suffering. They will buy cigarettes for clients, and oftentimes they'll get cigarette donations from tobacco companies for the shelter. So how can you really get money from a tobacco company and at the same time insist that your clients quit? And then while a lot of shelters are tobacco-free, they're not placing limits on smoking directly outside of the building. So one of our shelters in Gainesville, a lot of the people smoke right on the lawn outside, though a lot of people are wanting to get more smoke-free shelters. So homelessness and cessation. Just like we were just saying, about 20 to 30% of homeless adults have a serious mental illness. 30 to 50% either have substance use or dual disorders. And so we know that setting yourself up to most likely be using tobacco. Good news is that a majority of homeless smokers and a lot of studies insist that they want to quit and they're motivated to quit, but again, their confidence and their ability to quit is low. So that self-efficacy, again, is what we really have to focus on improving. So as you're talking to these patients, talk about their barriers to quitting. Find out ways to increase their self-efficacy so that they know they can do it. And you do that by focusing on the times that they've quit before, whether it was for a week, 2 weeks, or a month or 2 months. Talk to them about what they were able to do in that week and tell them you did it that time so you can do it again. Brainstorm on what's going to give them hope and give them that self-worth other than the tobacco, because again, if they're getting that self-worth and if they're feeling like that's what gives them hope and you take that away from the tobacco, we need to find out what can we replace that with so they still get those senses. Discuss why they want to quit, and again, as always, talk about how quitting will help them in their situation in dealing with their TB, because again, we're talking about TB patients. We want them to get to completion with their treatment. So low SES or formal education. This is defined as adults who have a lower level of educational attainment, who are unemployed, or who live at, near, or below the U.S. federal poverty level. So tobacco users with low SES or little or formal education, they do bear a disproportionate burden from tobacco. People living below the poverty level and people having low levels of educational attainment have higher rates of cigarette smoking than the general population. And then among the people who only have a GED certificate, smoking prevalence is more than 40%, which is the highest of any SES group. They are more likely to have limited access to effective treatment. They are misinformed about smoking cessation medications. They're less likely to receive cessation assistance, and they're more likely to be uninsured or on Medicaid compared to other smokers. And only 25% of smokers on Medicaid reported receiving any practical assistance with quitting. So they've expressed interest in quitting and they can benefit from treatment, but nobody is coming to them to engage in cessation. So this chart just shows the current use of tobacco among adults living below the poverty level compared to those living at or above the poverty level. So blue would show adults below poverty level, and red are adults at or above poverty level. So you see with cigarettes, adults below the poverty level are smoking at. They're using tobacco a lot more than those at or above the poverty level. That looks like it almost switches with that smokeless and even the cigars to some extent, because we're also including those big cigars, not just the little cigars. And even though we know they're bad, those still have a sense of almost like this rich feeling. I can smoke because I'm at this certain status level, even though it still has tobacco. I don't think cigars and smokeless have the same stigma attached to them as cigarettes, and I think that's why it also starts flipping a little bit in this chart with smokeless tobacco. So this is a similar chart as the previous slide, but now we're comparing tobacco use rates among those with a high school education and then adults with college degrees, and you can see that significant disparity in the cigarettes. And then again with cigars and smokeless, it almost starts evening out. So looking at lung cancer risk, populations who have the higher lung cancer risk are populations in the most socioeconomically deprived groups. They're people with less than a high school education. There are people with family incomes of less than $12,500. There are people living in rural areas that have a 18 to 20% higher rates of lung cancer than those living in urban areas. And this makes sense because lower income populations have less access to health care, so you can't catch some of these conditions early, which includes tuberculosis. So we know that people living in poverty smoke cigarettes for a duration of nearly twice as many years as people with a family income 3 times out of the poverty rate. So that just means they're smoking for a longer period of time than those who have a little bit more money. People with a high school education smoke for a longer duration of those with people with at least a bachelor's degree. And we know that blue-collar workers are more likely to start smoking cigarettes at a younger age and to smoke more heavily than white-collar workers. So again, as you're working with your TB patients, these are things that you need to keep in the back of your mind. And you learn a lot of this stuff by talking to your patients. Talking about secondhand smoke, low SES populations are more likely to suffer harmful health consequences of exposure to secondhand smoke. Blue-collar workers, again, more likely to be exposed to secondhand smoke at work than white-collar workers. And then our service workers, like our bartenders and our wait staff, report the lowest rates of workplace smoke-free policies than other occupation categories. And this is difficult when you are talking to your patients about quitting. And let's say they're ready to quit, but they are working at a bingo hall or they're working as a bartender and they're going to be around secondhand smoke. That's difficult. And I have still not found a perfect answer or a solution because it's not rational to tell somebody they're just going to have to quit their job so that you don't get access to secondhand smoke, because they also have to feed themselves and their family and take care to make sure that they are well taken care of. So I don't have a perfect answer for that, but it is something for us to keep in mind when we're talking to people, because they will still get that secondhand smoke, and we have to try to figure out a way to deal with that. So quit attempts. 39% of adult current daily smokers had no high school diploma or with no high school diploma attempt to quit smoking. It's not a huge amount. Adults live below the poverty line have less success in quitting than those who live at or above the poverty line. So they're struggling with quitting and staying quit. Adults with less than a high school education have less success in quitting than those with a college education. And then blue-collar workers and service workers are less likely to quit smoking than white-collar workers. So as you counsel, again, as you talk to them about TB, also talk about ways that tobacco cessation can help them. We need to know what their end goal is, what do they want out of life, and then see how quitting tobacco can help them achieve their goals. It's not about us, so we do want them to complete TB treatment or complete their TB treatment, but we need to find out what's going to matter most to them as well. So dealing with racial and ethnic minorities. Hispanic Americans are the largest racial ethnic minority in the nation. A majority reside in California, Arizona, Colorado, Florida, Illinois, New Jersey, New Mexico, New York, and Texas. And then keep in mind, where do we tend to see a lot of TB in our country? Most Hispanic Americans are of Mexican, Puerto Rican, Cuban, or South or Central American ancestry. So looking at our smoking prevalence among Hispanic Americans, they do smoke at lower rates compared to other groups. And if you look at the subgroups, Puerto Rican and Cubans are more likely to smoke and smoke more heavily than Mexican and Central Americans. And then those with a high school education are less or more likely to smoke. And we see that about 35% of Hispanics about 25 years and older do not have a high school education, so they are at risk for that. So what's contributing to this? Increased levels of acculturation. Essentially, the longer they're here, the more likely they are to smoke. There's this cultural attitude of fatalism, just meaning that negative life events are predetermined by this unforeseen power. It's almost like the cards were already dealt for them. What are they supposed to do about this? They're less likely to view themselves as addicted, and they have lower rates of health insurance coverage and access to health care. What we do know is that about 61% of them do want to quit, and they are more likely to make a quit attempt, but they're less likely to seek help in quitting. And we know that your best chance of quitting is by getting the medicine and getting that counseling. So we need to increase that number. It's great they want to make a quit attempt. Now we need to help them do that. And they view cessation in terms of willpower and then their strength or weakness of someone. They look about it in that terms. Essentially, I need to have the willpower to do this. I need to have the strength to be able to quit, and that's what's most important. So they're less likely to also use pharmacotherapy because they believe that willpower is enough. So in terms of treatment, we need to, one, increase education on tobacco addiction so that they realize they are addicted to this product, and then talk to them about pharmacotherapy. We have to explain it in a way that they're more likely to use it so they can be successful in that quit attempt. We need to use culturally appropriate resources and then emphasize that maintenance of family health, their social support, and problem-solving skills. And again, we're tying this all in terms of TB and their treatment. Family is important. We want them to be the healthiest they can be so they are there with their family. We want them to complete their TB treatment. What can help with that process? Quitting smoking. And most family members are usually on board with a family member quitting smoking. So African Americans smoke fewer cigarettes per day, and they tend to begin smoking later in life, but their smoking-related disease mortality is higher. They also have lower quit rates and see a higher incidence of mortality rates from tobacco-related cardiovascular disease and cancer. So what's contributing to this disparity? They have a higher nicotine dependence, and they do not metabolize nicotine as quickly as other groups. There's a preference for menthol cigarettes, and again, tend to be blue-collar workers with lower incomes, and we've already seen earlier that ties in directly with tobacco use. And then they're more likely to have under-addressed health concerns, and tobacco companies have really targeted this group of people. They also are more likely to have limited access to resources and experience life hardships, and we know all of those things contribute to using tobacco. So 70% report wanting to quit smoking and have a greater level of motivation to quit. So they are more likely to attempt cessation, but they do see lower quit rates and also lower rates of pharmacotherapy use. And they're less likely to be advised and counseled to quit smoking by clinicians. So again, that's where you're keeping this stuff in mind, and you're coming in to kind of fill in that gap that we're seeing. So they're likely to benefit from treatments that are, again, aimed at enhancing their self-confidence in quitting and something that's more of in a social support environment. Emphasize that relapse prevention, because if we're more likely to attempt cessation, that's great. Now we need to continue and talk about stress reduction techniques as well. We've seen that spirituality and use of faith-based programs not only work for tobacco use, but other health issues as well. So that's usually a great way to increase tobacco cessation. And then educate them on the different health effects and cessation medications. A lot of people don't use this stuff because they just don't know about it. Nobody's taught to them about it, so they're not going to try it. And then for Asian and Pacific Islanders, about 10.9% of Asian Americans reported current tobacco use in 2013. And current use is just meaning that they used tobacco in the past month. 28.1% of Native Hawaiians and Pacific Islanders reported current use of tobacco, and that's higher than our national average. Asian Americans and Pacific Islanders tend to be light non-daily smokers, and we're not covering it in this, but that was one of the groups I had an asterisk next to. Those light smokers are difficult because they almost don't see themselves as smokers. They don't think it's a problem. What's a few cigarettes here and there going to do to me? So that can be difficult. Korean, Vietnamese, Filipino, and Japanese had the highest smoking rates among the Asian subgroups. The good news again, 63.3% report that they want to quit, and about 40% report attempting to quit during the past year. So that is the good news about that group. So again, we just have to talk to these groups. The theme that seems to go together is increasing that self-efficacy, talking to them about medication, and talking to them about relapse prevention. So dealing with mental illness. Tobacco contributes more deaths in people with any mental illness than the primary behavioral health disorder. That's huge. Smoking is significantly higher in adults with any mental illness compared to those with no mental illness. They tend to smoke more cigarettes per month. They are less likely to have stopped over their lifetime, and they experience enhanced nicotine withdrawal. It's worse for them to try to quit than it is for more people because they're going to feel worse. That's not going to make a person want to quit. So those systemic barriers, the smoking rate among mental health treatment staff is significantly higher than the general population. About 30 to 35% of the staff smoke. It's hard to tell another group to quit smoking and no more smoke breaks when the staff also go on those smoke breaks and talk with their patients. It's a shared social activity. Providers believe that we were already taking away other issues. We're already trying to treat the mental illness. We can't possibly also treat the tobacco. The tobacco is making it better, and they don't realize it's making it worse. There's a lack of knowledge about that effective treatment, and again, tobacco industry has also targeted this group. So we see that tobacco dependence treatment provided during addictions treatment was associated with a 25% increased likelihood of long-term abstinence both from alcohol and illicit drugs. And it's the most cost-effective and morbidity-reducing of a lot of preventive services, but they have the lowest delivery rate. And that goes back to some of those systemic barriers we were talking about earlier. So their treatment is really, before we go into the correctional facilities, we've got to, one, dispel some of these myths that you can't treat somebody with mental illness or other substance use disorders and not treat the tobacco. We need to be able to treat that tobacco use. We've got to knock down a lot of those myths. We've got to educate about effective treatment, and we've got to let them know that treating these hand in hand help them. And again, the overall goal is that we want to help these people who also have TB. And that's a lot. It sounds like you're trying to chip out a mountain, but if you just chip out a little bit at a time, we can knock it down. So I'm briefly just touching on correctional facilities because we see that about 70 to 80% of all inmates in our U.S. prisons and jails smoke or use some type of tobacco product, and that's 4 times the national average. They have a high prevalence of low SES. They have a high prevalence of substance use and a mental illness. And then tobacco-related illness among inmates can consume a disproportionate share of the correctional facility's healthcare budget trying to treat that illness. So I feel like people would naturally say, but they're tobacco-free and inmates are not allowed to smoke, so this can't be it. But how many times do you find a way around something, or how many times do you do something you weren't supposed to do? Where there's a will, there's a way, and if they are addicted to nicotine and they want the nicotine, they will come get it. Just because the facility is smoke-free, even the staff will still find a way to use some type of tobacco. We used to go into some of the jails and prisons to do tobacco cessation, but because they are, quote-unquote, not supposed to be smoking, then they are, quote-unquote, should not need those cessation services, but we know that they're doing this. So this could also be a good opportunity just to talk with some of your local facilities about any programs they have in place. If you're already treating somebody who's in a correctional facility for TB, that's a great time. You already have them in your face to talk to them about cessation and the fact that smoking is bad for you and how you can help them quit. You might not be able to give them any of the medication because, again, they're not supposed to be smoking, but you can at least talk to them about that behavioral aspect. So what I want to end on, because I don't think I touched on any of our other webinars, is what if you treat TB and you also smoke? And we did a survey a couple years ago, and we do have providers who smoke. I would love to say I hope you went through the series and said maybe I should consider quitting. But at the end of the day, your job as a provider is to help your patient. You can even connect with your patient and let them know, I smoke, I'm still struggling with it, but overall you're there for their health and how you can make sure that they complete treatment. And we really wanted to do this webinar series because the research is continuing to show that association of TB and tobacco, and knowing that many of the groups disproportionately affected by tobacco are also affected by TB, it's really important that we start cross-training ourselves on how to provide that tobacco cessation counseling for patients, because it not only helps treating TB, but it's going to help your patient overall. And that's the whole reason we went into this health profession, is really to help improve a person's health and their quality of life. So if you've missed any of the webinars, I believe we all have them archived and they're available on the SNTC website. So with that, I think that's the end of this webinar, and we can take questions.
Thanks so much. Thanks so much, Stephanie. That was a great overview of treating tobacco dependence in these specific populations. If any of the audience has questions, please type them in the chat box now. Stephanie, I've got one question for you. Is where do you think the best place to go is to get resources for healthcare workers to support their efforts to provide tobacco cessation counseling?
The CDC website, hands down, is where I would go. And if you're interested in getting more stuff, we have some stuff in the office that we could ship to you if you're interested in getting some resources to help your patients. If you send an email to SNTC, we can get some stuff out to you that we have.
Well, great. Any last comments, Stephanie?
I think that's it. Thank you, everyone.